The goal of this presentation will be to review pharmacogenetics, in particular pharmacogenetics of malignant hyperthermia, pseudocholinesterase deficiency, prolonged QT syndrome, drug dose response relationships. We will also discuss the physiology and pharmacology of addiction. Malignant hyperthermia is one of the most feared conditions for anesthesiologists. The symptoms of malignant hyperthermia may include tachycardia. It may also progress to ventricular tachycardia or ventricular fibrillation, hyperthermia, muscle rigidity, muscle breakdown that may involve elevated levels of creatine kinase and potassium, the presence of myoglobin in the urine or serum, for which there may be even a cola-colored urine, metabolic acidosis, respiratory acidosis that may involve elevated end-tidal and PaCO2, decreased oxygen saturations, or disseminated intravascular coagulopathy. For the treatment of malignant hyperthermia, the number one goal would be to call for help. Consider utilizing the Malignant Hyperthermia Association of the United States, MHOUSE phone number and resources at 1-800-MH-HYPER. Discontinue volatile anesthetics and the usage of succinylcholine. Increase the minute ventilation for the patient. Administer dantrolene. The dantrolene dosage is dantrolene 2.5 milligrams per kilogram in a bolus, followed by dantrolene 1 milligram per kilogram every 4 to 8 hours for 24 to 48 hours after the incidence of malignant hyperthermia. Begin cooling measures. Treat arrhythmias and electrolyte disturbances. Monitor the patient at baseline and every 6 hours for the presence of their blood gases, electrolytes, creatine kinase, blood and urine myoglobin, and coagulation profile. Maintain urine output. Consider mechanical ventilation or continuing mechanical ventilation, and consider continuing or replacing invasive monitoring. Monitor the patient in the intensive care unit, as there may be a 25% chance of recrudescence of malignant hyperthermia symptoms. Malignant hyperthermia is a pharmacogenetic disorder. It's triggered by volatile anesthetics or depolarizing muscle relaxants, such as succinylcholine. It has a genetic transmission that may be of variable penetrance or expression. Malignant hyperthermia is typically an autosomal dominant genetic disorder with more than 200 mutations. Multiple chromosomes may be involved. Typically, 19q 13.1 to 13.2 is part of the chromosome that codes for skeletal muscle ryanodine receptor, or the RYR1 receptor. This receptor releases calcium from the sarcoplasmic reticulum. Chromosome 1q32 encodes the CACNA1S gene, which is an alpha-1 subunit of the voltage-gated dihydropyridine receptor. 17q11 to q24 alters function of a sodium channel, whereas chromosome 7q21.1 codes for a dihydropyridine voltage trigger for the RYR1 receptor. There are several associated diseases that may resemble the symptomatology of malignant hyperthermia. There are also specific ryanodine receptor mutations, or the RYR1 receptor mutations, through central core disease, King-Denborough syndrome, congenital fiber type disproportion, centronuclear myopathy, multi-mini core disease, Nemeline myopathy. Mutations that involve the CACNA1S mutation may contribute to hypokalemic periodic paralysis, of which there are two types, paralytic or myopathic. In addition, muscular dystrophies pose an increased risk for malignant hyperthermia. Duchenne muscular dystrophy is an X-linked recessive disorder that involves the complete loss of dystrophin from its affected patients. In Becker muscular dystrophy, this is also an X-linked recessive disorder, and there's a partial loss of dystrophin. Both Duchenne muscular dystrophy and Becker muscular dystrophy affect men more than women. Myotonic dystrophy is an autosomal dominant disorder. Should a patient undergo a suspicion for malignant hyperthermia, it is of importance to be able to assist the patient with diagnosis confirmation. The patient or family members should be referred for further investigation. These can be done through one of two different methods. Genetic testing involves the isolation of familial mutations or mutations of one of the known chromosomes. The patient may also undergo a muscle biopsy. With a muscle biopsy, the muscle will undergo caffeine halothane contracture test, or a CHCT. In the caffeine halothane contracture test, it is performed at an approved malignant hyperthermia diagnostic center. Muscle bundles from the vastus lateralis or the vastus medialis are harvested under general anesthesia or a femoral nerve block from the affected patient or their family members. The muscle bundles that are harvested are exposed to sarcoplasmic reticulum calcium-releasing agents, such as halothane, caffeine, or ryanodine, and the muscle segments are evaluated for their isometric contracture. Moving on to the next disease component, butyrylcholinesterase is an enzyme produced by the liver. It's found in the plasma, and it hydrolyzes choline esters. Succinylcholine is one of the esters which is hydrolyzed in the body before reaching the neuromuscular junction. 90 to 95% of succinylcholine is hydrolyzed before it ever reaches the neuromuscular junction. The 5 to 10% of succinylcholine that remains functions as an acetylcholinesterase receptor agonist, which causes the depolarization of the motor end plate. Fasciculations occur within 60 seconds after the administration of succinylcholine. However, the function of the muscle returns to normal standards within 5 minutes. In butyrylcholinesterase deficiency, this is a common disorder which may affect approximately 1 in 2,500 patients. This may also be called pseudocholinesterase deficiency, as pseudocholinesterase deficiency tends to be a more common name. Pseudocholinesterase deficiency involves the slow metabolism of choline ester drugs, such as succinylcholine, mivacurium, or ester local anesthetics, such as procaine or cocaine. Often clinically diagnosed after prolonged respiratory paralysis with succinylcholine, as many patients may not be aware of their butyrylcholinesterase deficiency until after an anesthetic that involves succinylcholine administration. The patient typically receives respiratory support until the passive diffusion of succinylcholine occurs from the neuromuscular junction. In butyrylcholinesterase deficiency, there are mutations of chromosome 3E1. This involves a BCHE gene. Butyrylcholinesterase deficiency is autosomal recessive for an enzyme for the production of butyrylcholinesterase. In the BCHE gene, for which a mutation occurs, there may be lack of functional butyrylcholinesterase through one of two different methods. Either butyrylcholinesterase is not produced, as the mutation prevents the production of butyrylcholinesterase, or butyrylcholinesterase may have an abnormal function, as the BCHE gene coded for a protein which does not provide the same capabilities as the original butyrylcholinesterase. There may also be physiologic butyrylcholinesterase deficiency. This typically occurs in the neonates, elderly, or in pregnancy states for which butyrylcholinesterase is not produced at physiologically functioning levels. There's also acquired butyrylcholinesterase deficiency, which may be acquired through malnutrition in patients who have experienced burns, chronic disease such as renal or liver disease, malignancy, or in patients who have taken drugs such as cyclophosphamide, metoclopramide, glucocorticoids, or other drugs. The diagnosis of butyrylcholinesterase deficiency is typically made after the patient experiences an episode of prolonged paralysis after the administration of succinylcholine. These patients who experience prolonged paralysis typically undergo a test involving dibucane. Dibucane inhibits butyrylcholinesterase enzyme. The test is called a dibucane number, and the dibucane number is a reflection of the percent of butyrylcholinesterase activity that is inhibited by dibucane. The lower the percent inhibition, the less enzyme activity. In other words, the lower the dibucane number, the less that butyrylcholinesterase is a functioning enzyme. A normal dibucane number is 80 to 100%. This means in patients who have a number of 80 to 100, their enzyme is not inhibited, and thus they have full butyrylcholinesterase activity. In a patient who is homozygous recessive, the dibucane number is less than 20. This means that there's less normal enzyme around, and the patient does not have normal enzyme due to their homozygous recessive state. The patient may be heterozygous for their butyrylcholinesterase if their dibucane number is between 20 to 80. Moving on to the next pharmacogenetic study, we'll talk about prolonged QT syndrome. The QT interval is the beginning of the Q wave to the end of the T wave. With prolonged QT, there's myocardial repolarization. There's increased risk for torsades de pointe, which is a polymorphic ventricular tachycardia. Should a patient experience torsades, the treatment typically involves magnesium sulfate. In addition, with prolonged QT, symptoms may occur such as palpitations, syncope, seizures, and sudden cardiac death. Men typically have a prolonged QT greater than 45 milliseconds or 0.45 seconds. In addition, women have prolonged QT if their QT interval is longer than 0.45 to 0.45 seconds or 450 milliseconds to 470 milliseconds. Long QT syndrome may also be acquired. Acquired long QT syndrome may be caused by drugs such as antiarrhythmic drugs, quinidine, amiodarone, procainamide, antihistamines such as terfenadine, macrolide antibiotics such as erythromycin, psychotropic medications such as haloperidol and thyroridazine. With acquired long QT syndrome, patients may experience bradycardia or pauses. Risk factors for acquired long QT syndrome include a high concentration of medication, concurrent usage with other medications that also contribute to QT prolongation, or other medications that may inhibit the cytochrome P450 enzymes. Risk factors for acquired long QT syndrome also include grapefruit juice due to its inhibition of the cytochrome P450 enzymes. Should a patient have baseline QT prolongation, they may be at increased risk for further propagating acquired long QT syndrome. In addition, electrolyte disturbances may predispose a patient to acquired long QT syndrome. There's also congenital long QT syndrome, which typically has an inheritance pattern. There are 13 different subtypes of long QT syndrome. In long QT syndrome 1, this involves 30 to 35% of the cases. This may involve prolongation after epinephrine of the long QT syndrome. The genes that encode for the long QT syndrome for LQT1 involve KV-LQT1, which is an alpha subunit of the outward potassium current, or the KCNE1, which is a beta subunit or cardiac protein MINK. Both KV-LQT1 and KCNE1 form the slow component of the outward potassium current. This involves chromosome 11. The mutations of chromosome 11 that promote LQT1 suppress the outward potassium current. KV-LQT1 prolongs the action potential. There may also be a gain of function mutation to KVL-QT1, or the alpha subunit. This is associated with familial atrial fibrillation, or congenital short QT syndrome. So mutations that suppress the activity prolong the action potential. Mutations that increase the function of KVL-QT1 actually shorten the QT interval. In LQT2, this is 25 to 40% of the cases. There's a mutation to gene KCNH2 that affects the rapid component of the outward potassium channel. And this gene is located on chromosome 7. Additional subtypes of congenital long QT syndrome exist. LQT3 involves 5 to 10% of cases. This involves a mutation to the sodium channel on chromosome 3 causing impaired activation. This gene is SCN5A. This may also contribute to Brugada syndrome. One of the key components of LQT3 is that the events typically occur at night or during sleep. There may also be compound mutations involving more than one subtype, and this may increase the prolonged QT interval. Rett syndrome is one of the conditions involving QT prolongation. This is typically involving a sudden cardiac death in a female, and this involves mutations in the MECP2 gene. Congenital long QT syndrome may have more than one phenotype expression. Even though there may be more than one genotype and multiple different subtypes, there are typically 2 phenotype expressions. In Romano-Ward syndrome, this is an autosomal dominant expression that has long QT syndrome without deafness. In Jervell-Lang-Nielsen syndrome, it is autosomal recessive, which involves sensory neural deafness. Mutation to the alpha and beta subunits of the potassium channel may be involved in Jervell-Lang-Nielsen syndrome. This involves the KCNQ1 in LQT1 syndrome, or in KCNE1, which is LQT5. We will shift gears to discuss the genetics of drug metabolism. Pharmacokinetics involves the drug absorption, distribution, metabolism, and excretion of the drugs. Drug elimination involves metabolism, typically by the liver, or excretion, typically by the renal system. Genetic polymorphisms exist within the different ethnic groups in society. Cytochrome P450 enzymes are typically one of the more commonly affected genetic polymorphisms involving drug metabolism. There are different metabolizer phenotypes that involve a poor metabolizer, an intermediate metabolizer, or an ultra-rapid metabolizer. And these may vary by ethnic distribution. The different metabolism phenotypes involve 2 different actions on the drugs. There's a prodrug, and for a prodrug, metabolism is needed in order for the drug to have active properties. In people who are poor or intermediate metabolizers, they may have slow metabolism of the prodrug. This leads to an accumulation of the prodrug, which may have poor efficacy, as there is little of the active drug that exists in the body. In a person who is an ultra-rapid metabolizer, they have good efficacy, as the prodrug is rapidly metabolized into an active drug, and there is a rapid effect. For metabolism of active drugs, this is where metabolism is needed in order to be able to inactivate the drug. In people who are poor or intermediate metabolizers of active drugs, there's good efficacy such that more of the active drug remains, or accumulation of the active drug occurs. These people typically require lower dosages, as there's more active drug that is still remaining in the body. In people who are ultra-rapid metabolizers, they actually have poor efficacy of an active drug, as the drug administered in these people with ultra-rapid metabolism, the active drug is quickly inactivated. These people typically require higher dosages of the active drug in order to be able to have a physiologic effect. The cytochrome P450 enzymes play an important role in drug metabolism. There are several different types of cytochrome P450 enzymes. In cytochrome P450-2C9, or CYP2C9, there are different versions of cytochrome P450-2C9, such as CYP2C9-2 and CYP2C9-3. If these cytochrome P450 enzymes are affected, this affects the metabolism of drugs such as glipizide, losartan, phenytoin, warfarin. In particular, on warfarin, mutations to the CYP2C9 enzyme may reduce warfarin clearance. Lower dosages or excessive accumulation of warfarin may occur in people who have alterations to their CYP2C9 enzyme. With cytochrome P450-2C19, or CYP2C19, mutations in folks who have CYP2C19-2 and CYP2C19-3 have poor metabolism. CYP2C19-17 patients actually have ultra-rapid metabolism. These typically are of the Swedish, Ethiopian, or Chinese ancestry. CYP2C19 is involved with the metabolism of proton pump inhibitors. These drugs are metabolized to inactive forms by the CYP2C19 enzyme. Also, citalopram, diazepam, and imipramine are also metabolized by the CYP2C19 enzyme. In cytochrome P450-2D6, CYP2D6 metabolizes 25% of all drugs at some point during its metabolism cascade. There's more than 75 different allelic variants. With CYP2D6 versions 3 to 6 and version 17, these are the ones most commonly presenting in the phenotypes. Codeine is metabolized by CYP2D6 to active morphine. In people who have one of the allelic variants of CYP2D6, they may be a poor metabolizer of codeine, for which they have minimal codeine response or minimal analgesic effect, as morphine is not produced by these phenotypic variants of CYP2D6. We will shift gears entirely and begin our talk on addiction. Addiction is a biopsychosocial process. It is biological, which affects neurotransmitters of the brain and body functions. It is also psychological, which alters brain processes. There's also sociological, which alters behavior and interactions. Neurotransmitters involved in addiction include dopamine. Dopamine is typically a reward or stimulation neurotransmitter, and it can be affected by cocaine and methamphetamines. Serotonin affects the mood, sleep, and appetite as its functions of the neurotransmitter, and hallucinogens or tetrahydrocannabinol may affect the function of serotonin. GABA is a neurotransmitter involved in anxiety and sedation, and benzodiazepines affect levels of GABA in the body, and endorphins are involved with pain, and opioids may affect the endorphin levels of the body. Buprenorphine is a partial mu receptor agonist that's typically given to patients who have addiction concerns. Buprenorphine is a lipophilic semisynthetic drug that's a thebaine derivative. With its partial mu agonistic effects, it provides analgesia with low mu receptor occupancy. Buprenorphine may also precipitate withdrawal with mu dependence, and it's not easily displaced from the receptors. It has sublingual absorption, and with this, there's also the ability for first-pass metabolism and gut metabolism, to avoid the first-pass metabolism and gut metabolism. Buprenorphine also has some kappa antagonistic effects. There's mu receptor upregulation 48 to 72 hours after discontinuing, which may increase opioid sensitivity. With buprenorphine, in patients who are undergoing elective procedures or surgeries with mild to moderate pain, sublingual buprenorphine with or without naloxone may be given in its total daily dose, divided into 3 or 4 times a day dosing. In patients who are still on the buprenorphine for breakthrough pain, multimodal analgesia with an opioid is recommended. High mu receptor affinity and potency medications should be given, such as fentanyl, hydromorphone, and the goal would be to avoid meperidine. Also consider a patient-controlled analgesia. Buprenorphine for elective procedures or surgeries with moderate to severe pain. It is recommended to discontinue buprenorphine 2 to 5 days before surgery. Initiate alternative mu agonist, such as methadone or morphine, in the interim time frame after discontinuation of buprenorphine and prior to the surgery. You would like to titrate the drug to prevent withdrawal. And breakthrough pain should be treated with a full mu receptor agonist. In patients who are taking buprenorphine for an elective procedure or surgery with MPO status, the goal would be to discontinue buprenorphine in the 2 to 5 day time frame prior to surgery, and to continue a mu agonist PCA or mu agonist pain medication. A high mu receptor affinity and potency medication such as fentanyl or hydromorphone should be used, and also to avoid meperidine. The goal would be to titrate the mu receptor medication to be able to prevent withdrawal. In acute pain or emergency surgery in patients who are taking buprenorphine, discontinue the buprenorphine in the perioperative time frame and initiate a PCA or patient-controlled analgesic. Titrate the opioid to prevent withdrawal. Multimodal analgesia with an opioid is also recommended, and again, a high mu receptor affinity and potency medication such as fentanyl or hydromorphone should be used, avoiding meperidine. Naloxone is a medication that's used for the reversal of opioid effects. In an oral administration of naloxone, you have a reverse of the GI effects of opioids. Naloxone can precipitate withdrawal, as there's no longer the opioid effects that have been from the previous opioid administration. Addiction has multiple different facets. There's the tolerance portion of addiction. And with tolerance, there's decreased drug effectiveness due to chronic administration and resistance of the body to the effects of the drugs. 2 different types of tolerance exist. Pharmacokinetic tolerance is decreased drug quantity that reaches the target. This is due to enzyme induction or increase in enzyme numbers, for which the drug is metabolized quicker. In pharmacodynamic tolerance, there's a decreased cellular response. This can also be due to a decrease in receptors available for the drug. Tolerance may also include dependence. Dependence is a physiologic adaptation in response to chronic administration. With dependence, there's negative consequences with cessation of the drug. This may precipitate withdrawal symptoms. Often, in patients who have drug dependence, there's often tolerance along with it. Addiction is the compulsive use of drugs for non-medical reasons. In patients who are addicted, there's a psychological dependence on the drug, and this may affect the patient's behavior.